Okay, do you hear me? Okay, let's get started. Welcome to the Radiation Oncology Committee meeting. And as you know, I have been the chair of the committee since June, and it has been my privilege to work with you all. And also it has been such a pleasure to get to meet you in person and also virtually. I look forward to working with you all. And just please feel free to reach me through email or text or just call me. So we have a packed agenda. So let's get started. So the first is a report from the executive officer, Dr. Kachnik.
Are the slides all loaded? Oh, you mean like you loaded them all?
Yeah, they're all.
Oh, nice. Okay. Thanks. Well, good afternoon, everybody. I didn't even think to put disclosures for this, so pretend disclosures. So do we have any new members that this is our first meeting? Hello. So because of that, I'm going to go through some more stuff. So there are lots of things you can do, and I think everybody except you may know this, but obviously we can actually generate our own trials now. And on my next slide, I'll give some examples. Secondary endpoints on developing protocols, especially if radiation's a component. We have a lot of folks that are also interested in imaging that come to RadOnc. Secondary analyses after the primary endpoint of a trial is done. We've been really good about doing those, and some actually change practice. So here are some of the trials that in the support groups are being developed. The top one's a surgical one, but we have two radiation. One is, and maybe we'll hear about them today. One is from Jeremy Harris, who I think's here, and he has a nice sarcoma trial that's now probably going to be a phase 2-3 potentially. And I think he's done tremendous work with all of our research bases so that we'll have energy and some of the other ones engaged for accrual purposes. And then I don't know if Leslie Ballas is here. I don't see her. Maybe Leslie, you're on the Zoom. I know you have one for bladder preservation, and yours is moving along and going to triage soon. Jeremy's actually went to triage, got somewhat approved with a number, but now has to go back because made some refinements. And then remember last meeting, I spoke about the Clinical Trials Innovation Unit, the new sort of NCI project where you don't have to go through the NCI for the steering committee review if you have a trial more than 100 or more patients. So SWOG submitted a few that were kind of voted on, and one of them was from Dr. Schwartz, who's our keynote, on imaging radiomics for lung cancer, and it actually got chosen. So
is it final now?
No, but
Almost.
almost. It got chosen to do something. Whether it actually gets funded right now will be on my last slide. There's also, I always remind people because we don't use it. There's travel money. It's called MAD money, and you just can go on the website and apply for it before any meeting. We tried, when we get knowledge of it, we also send it around to the group, but it's low-hanging fruit if your institution doesn't really fund you enough to go. And then we're reaching our next sort of round of HOPE funding opportunities. I know many of you have applied, many have been successful. Please snap a picture. Again, low-hanging fruit. There's maybe 4 to 6 for each of these awards that are applied. So you have a really good shot, and we're happy if you want to talk it through or work on it with us, we're happy to help. Recent news. So 6 months ago, I shared that we were having our group chair elections, but there was only a sort of a partnership on the ballot. Well, as you would guess, they got elected. So Doctors Lara and Hirschman will be our new group chairs. However, NCI about a week ago announced that there'd be a 1-year delay in all of our grant renewals, like here, energy, wherever. So what does that mean? It means a lot of things. It means, well, we're guaranteed the same amount of funding for 1 year. So I suppose same is better than less. And I heard, but this might be rumor and not factual, that the reason it's happening is not because the government is closing, but that Congress agreed to increasing funding. But if they did it now, we wouldn't get an increase. If they delayed, maybe we would. So that could be rumor, but I've heard it from 2 different sort of higher up folks. I talked about the Clinical Trials Innovation Unit. Here's Dr. Schwartz.
Making the grand entrance.
Just couldn't find the room.
And then the last thing actually is a really nice thing. So in June, the SWOG executives had a research retreat with all of our committee chairs, and one of the many strategic and vision listings that we came up with was the need to hold strategic retreats for each of the committees. So we have the opportunity here, and it might even be some good time to start brainstorming on needs for radiation oncology in terms of clinical trials, and almost kind of like assigning folks to work on each of these needs and brainstorm on that. That would be my suggestion, because we never really have time to do that as a group. So maybe at one of our live meetings coming up, we can set some time at the beginning, or at, tomorrow seems to be a popular time for some of these retreats, that we can meet together to do this.
Okay. Is tomorrow?
Well, no, we can't do it tomorrow, but we'd have to sort of petition, because I don't think they want to have like 5 committees doing it at the same time. So if this is of interest, I think, you can poll folks when, like before or after. Do we want to do it at the next meeting or in a year? And then we could probably ask Dana.
Yeah.
And I think that's it. Folks have any questions?
Hey, Lisa, this is Evan Wutherick. My question is, if we have concepts that we're kind of starting to think through that might come through the Radiation Oncology Committee, do we have a statistician that's been assigned to us that we could meet with to try to help?
Yeah, me. No.
Yes, we do have our own statistician now, and she could not make it today. So today, if you have burning question, please ask Hong-Li Lee, sitting right there, covering for our assigned statistician, Danica Lu. And also I have our, our department, our committee's own protocol coordinators too. Okay.
Awesome.
And,
do you think you'd be able to send out Danica's contact, if you said Danica, contact information after the meeting to the attendees?
Sure, I'll make sure I put it in the tweet.
Awesome.
But maybe, I mean, and Evan, it could be what you've presented here before, which was intriguing. But if these are new concepts, it might be best for us to kind of hear it through once and prioritize, because while we might have a statistician assigned, I don't think like we're going to be a disease site group and that we can just automatically work on 3 trials thinking we can open them in a year. So I think we have to prioritize too. Maybe I think 1 every 6 months might might even be a lot, but we can try for something like that. So I think Evan, before we start doing stats, just maybe give us an idea of what it is, and maybe we can run it on the next committee call.
Yeah, no, I wasn't really asking for sort of like a in-depth stats thing, but I've found that when starting, sometimes even like a 15 or 20 minute, meeting with a statistician is sometimes helpful, just to kind of get your get a scope of the, how many patients would this really be, and it can help you decide like whether an idea is even feasible from the start.
Got it. Well, I think that's fine.
Yeah, as I have been telling everyone during the monthly meeting, the way I see this, if you have any idea to discuss, just let me know, and we start from there, and then we make the right connections to the right disease site committee, and of course we'll have Dr. Kachnik, our EO involved, and we'll move from there. So our monthly meeting, I was thinking about even having it like every other month, but I think that's too complicated. But I think we just have a monthly meeting, and then it could be as short as 25 minutes, or sometimes it could go all the way. I think it'll be simpler for clinicians' calendar. Yeah, but I'm going to talk about it later on for the timing of it.
And I think, we have a great opportunity with Dr. Schwartz and his imaging chair colleague, Dr. Knopf, being here, in that, we might even have time today to kind of brainstorm a little bit of how we can use radiomics on some of the data sets that we have that had radiation treatments in it. All right. Any more questions on the Zoom world? All right, hearing none, thank you.
Great, thank you. So while Dr. Schwartz is approaching the podium, let me introduce him here. Well, it's my great honor and pleasure to introduce our keynote speaker, Dr. Schwartz. He received his BA and a BA in economics and MD from Boston University. He then completed his diagnostic radiology residency at New York Hospital, Cornell University, and fellowship at Brigham and Women's Hospital at Harvard. He started his academic career at Memorial Sloan Kettering Cancer Center and rose through the rank to be a full member. He moved to New York Presbyterian Hospital, Columbia University Medical Center, and served as the chair of the Department of Radiology between 2009 and 2022. Of interest to us, radiation oncology, is that he also served as the interim chair of the Department of Radiation Oncology for 4 years at Columbia. Earlier this year, he returned to Memorial Sloan Kettering Cancer Center as the chair of the Department of Radiology. Currently, he is also chair of imaging committees at SWOG and Alliance, and serves on the NCI Clinical Imaging Steering Committee. His work over the past 2 decades has focused on quantitative imaging biomarkers in oncology, in particular, utilizing advanced computational techniques for response assessment. He has developed quantitative techniques to automate the calculation of tumor burden, as well as metastasis in specific sites. He has participated in multiple national and international efforts at image standardization and the creation of response-based criteria, including the international standard for RECIST, as you all know. Now, as some of you may know, I plan to bring AI-based research portfolio to our Radiation Oncology Committee, and I could not think of a better person to help us kick it off than Dr. Schwartz. The topic of his presentation is New Paradigms for Image-Based Response Assessment. Thanks so much for accepting our invitation to discuss your research, Larry.
Thanks. Thanks very much. And you see, I wore my sweater, especially for Lisa.
It's a Columbia.
Yeah, well, NYP, it's still there. So the chair of Radon thing was supposed to be for 3 months. I was promised it was supposed to be for 3 months. That's a whole. Exactly. That's a whole long story, but it's a very interesting story, but I still got my way. So really, thank you for a kind introduction. And I really do hope we can kind of coalesce around AI to really be able to do even more work together than we've been doing. So, many of you are familiar with the problem statements of oncology drug development being inefficient, really because of a few issues. One, a good one, that we have more active drugs leading to greater use of randomized phase 2 trials. However, we're continuing to use the same old endpoints that we've used. And, even, we really don't have appropriate error bars around our classic response criteria. You could have two different studies with the same drug regimens and really give you different response rates. Not really well understood why. Despite this, in general, the greater magnitude of response is associated with a better prognosis for the individual patient. And there may not be a stronger correlation between response and survival. And what's probably lacking there is reliability of the imaging, reliability of the metrics, also the biologic relevance that we're talking about. And, are we using actually the right metrics? So what I'd like to show a little bit of is how AI, how radiomics, how some of these new metrics actually can be used with better image analysis, really to replace, supplant, be an adjunct for our commonly used criteria of response rate and progression-free survival. So response rate, a few years ago, we wrote a paper in JAMA Oncology. It's kind of a meta-analysis of approved trials that had used response rate. Then we were told that the FDA is going to write an editorial about it. That's very nerve-wracking. They wouldn't give us an advance copy. So we were very nervous about that. But it ended up being, quite positive. And just quoting one line, for regulators, more sophisticated and refined response metrics will assist in identifying future breakthrough therapies and in developing better surrogates to predict long-term clinical outcome. So one project that we started many, many years ago now, and I joke about this, or not really joke about this, if I knew how long it was going to take, I would have never done it. If I knew how important it was, I would have spent twice as much time doing it. I'm not quite sure which is actually the right answer, but the feeling was that we actually hadn't collected a lot of imaging, but was really relying on case report forms, which really give you very, very little data, right? You guys know that, you're imagers. I know I'm preaching to the choir. But the idea was, as we begin this work with AI, as we begin, looking at multi-parametric methods for response, for progression with other biomarkers as well, let's really start with the imaging so that if our metric doesn't work, we don't have to be uncertain whether it was an incorrect image analysis. We would always have the imaging available. So the idea was to do a quantitative burden assessment of tumor burden, that meaning volume, all lesions, target, non-target, all measured, assessment of features, radiomics, organ, metastasis, and at the pixel level. And this was fundamental groundwork to understand the accuracy, reliability, reproducibility, and adaptability. These are actually 12 trials that we got together with the FNIH. I don't, though a lot of people talk about data sharing, as we talk more about it, in some ways, I'll just editorialize, there's even less data sharing. In some ways, I'm not sure that we'd actually get all these trials. Some of these trials we never physically got. We had to be on a company portal or a share portal to do the analysis, so that can be hard as well, but it was access to data. And really our goal was to create a database such that any metric or model could be applied against the gold standard of tumor burden, not RECIST. So as I said, probably not as eloquently as this sentence, if the model does not work, the tumor burden or measurement methodology cannot be faulted. And really the two that we found worked and that we really want to now take forward and explore more is really, radiomics for response and this modeling, conditional or kinetic modeling for a different measure of progression-free survival. So first, radiomics, it's not new. You've all seen this image. I joke that, we've probably seen this image more than in meetings than we've seen it in clinical practice. But the point is, this is a patient with Gleevec and GIST. You have the baseline, the follow-up, the tumor's not shrinking in size, but its features are changing. And yes, we could see this on PET effectively as well. Basically, the PET signal is turned off. But in fact, the radiomic signature, the heterogeneity of this tumor, we could easily measure now as well. So radiomics, it's the ability to extract quantitative features from medical imaging using data characterization algorithms, which has the potential to uncover disease characteristics difficult to identify with human vision alone. So this is in GIST. This is, one of our first studies with sorafenib, the multi-targeted kinase inhibitor in HCC, where you see the large HCC, just like the GIST tumor after Gleevec, it becomes necrotic, cystic change. Pathologists hate when we say that, but clearly there's change. I show 3 slides, 3 images of baseline and 2 follow-up on the right, where we can now actually quantify it. So what's new is our ability to accurately, reliably, reproducibly quantify it with measurements that we could truly, see these changes, measure these changes, and measure them very, very accurately. Now, it is less.
Would you mind repeating?
Yeah, so I could. So the question is it immune to the 10% variability? I would say it's never immune, but it's less. It's more immune, I should say. It's better, and in fact, I would argue that the 10% is actually with some of these automated methodologies that we use, and that the hand done ones are actually even greater than that. The other point, though, is that you can measure many more aspects of it. I'll answer that question in even more detail here. This is the basis of the Choi criteria, which absolutely works well, but at a single center, because it's measuring small differences in Hounsfield unit values, so density, and small differences in measurement. Now, by our segmentation techniques that you're all familiar with, and actually measuring radiomics features such as heterogeneity, that's completely immune to density changes and to enhancement. We're actually measuring the heterogeneity, which could be measured almost equally well on a contrast or non-contrast study. So, for many of these radiomics features, the ground truth that we've done is to develop a standard set of them, which can be done on multiple scanners with multiple settings without the concern about observer or machine variability. The other thing that's new is our ability to link the radiomics with specific gene mutations and other types of profiles. So this is the EGFR. This is an EGFR mutant lung tumor. You notice it's less dense. Our clinical colleagues started calling this ghosting when we identified this, but in fact, it's much more than ghosting. And again, with this careful segmentation and measurement here, measuring the percent ground glass opacity, we're able to see differences in these tumors. I'll answer your next question. Somebody's going to ask, we're not going to replace pathology. We're not going to even replace, circulating tumor samples. But I think as an adjunct, as well as to really understand progression and regression of fractions of the tumors and different metastases, I think this is very, very powerful. So now quickly to just go through some clinical examples. So here's a baseline radiomic signature in non-small cell lung cancer. So the idea was to collect prospectively, analyze retrospectively, 3 multi-center clinical trials with a training, a calibration, and then a standalone independent data set. Patients were treated both with immunotherapy as well as chemotherapy. And when we looked at all the features, and we did a feature reduction, and offline, we can go through a lot of this with you. Tumor burden in the liver, tumor burden in mediastinal lymph nodes, component 6, which is a measure of tumor heterogeneity, and overall tumor burden were the 4, and we've actually found the 3 to be most helpful for at baseline prognosticating patients. So this is in the validation set. This is the above and below the threshold that was determined in the training and the testing set. So and texture alone actually was an independent prognosticator as well. So I think some real benefits potentially here. We have to think about designing clinical trials now using this information. A different data set here with immunotherapy. This is an example of a patient who has rapidly progressed, and the RECIST response, the signature response here, and this is a melanoma patient, is all consistent. But you could see here, this is a patient with pseudoprogression. Baseline 12 weeks, 18 weeks, but then at 24 weeks, the tumor shrinks. And in fact, despite RECIST, basically the size, showing that this patient would have a short OS, the signature at 12 weeks actually did predict that the patient would do okay. Now, it's interesting, this data set, this was a Merck data set with pembrolizumab. There were 11 patients that had pseudoprogression, and the signature was actually able to identify 9 of them, 9 of the 11. I know that pseudoprogression isn't as critical anymore. We could some people say, just ask the patient how they're feeling, and that does pretty well. And I'm sure it does. But as a proof of concept and as a signature, I think it's very helpful. Here you could look at all the different approaches. And this is JAMA Oncology last year. Here you could look at all the different approaches. The signature, the 4 components that made up this signature. This was a baseline and a follow-up signature. Here you see that, again, we did quite well here with the overall signature, and all the components independently added to it. In melanoma, the baseline tumor burden, I think, as you intuitively know from immunotherapy and melanoma, isn't that important at all. But there's heterogeneity, and in particular, in melanoma, the change in heterogeneity was very, very important. And these are the Kaplan-Meier curves. You see really here on the left is RECIST at 12 weeks. On the right is the signature, really able to tell the long-term survivors. And you see it kind of spreads apart for the rapid progressors, the PD-like, which is basically an increase in size and a lack of change in the texture. That's what you're basically measuring. I also think radiomics, very importantly, has to be intuitive, right? It can't be a black box with 50 features in it. You guys aren't going to believe it. I wouldn't believe it. Colorectal, much the same here. Here's a patient obviously with a partial response that we show and this is JNCI, I think about 3 years ago. I can give you these references. But this is more interesting, right? 2 different patients that really look stable disease. But again, you look at some of the texture features of it. One shows short overall survival. The other shows a very long overall survival. So again, really the ability to distinguish on an individual patient basis, but here you see the spread in the Kaplan-Meier. So kind of just in summary, in part what we're trying to do is, we recognize that this can't be disease and therapy specific. We'll be doing research for the rest of our lives instead of applying this to patients, but we can come up with some aggregate signatures that work pretty well, certainly better than RECIST does. And that we see here as an example. So then the next technique that I want to talk about is basically a better PFS. And actually, this is the topic of our CTIU proposal. And this is work that, we started with some of the measurements that we had, but really picked up steam with our colleague Tito Fojo at Columbia and the great work that he's done in this area. So basically, the rate of growth, G, correlates very, very highly with overall survival. Knowing the rate of growth and regression allows us to not only predict who will derive long-term benefit, but also potentially what subsets can receive novel combination therapies. And the rate of growth is really easily determined by a few formula, the most common being this exponential formula where it's G and T, T being time. The nice thing about T being time is it's actually in days. So you don't, like PFS, need these standard, time points to do this assessment. Okay, so here's how it works. Basically, what we see on the scans is the line in blue, right? It's a combination, but the line in blue, most of the time, patients initially, their therapy is working, it decreases. That's the regressive component, which is the majority of it. But there's almost always a resistant component that's growing from baseline. And ultimately, the resistant component is bigger than the regressing component. Over time, that's when you have nadir, and that's when the tumor starts to increase. The blue line is actually the sum, or the blue curve, sorry, is actually the sum of the green and the red. That's what you're seeing. That's what you're measuring. So, if you look at these 3 time points on the curve, at the last time point in circle, right, you still think that the patient is doing well, but in fact, they're starting to progress. And using fairly simple mathematics and 3 or more time points, you could actually measure this distance, this difference. So you could start to see, I don't know if that's the right word, measure, see, quantify that component of the tumor that's growing because it's not continuing to shrink along the line of regression. So let's take these 3 patients, A, B, and C, hypothetical patients. They start at a tumor burden of 1. This is hypothetical. And unfortunately, death occurs at a tumor burden of 12 or 11 and a half. But let's look what happens to them early on. So now this is in the first 90 days when you see them in clinic. When you see them at day 45, or when you measure them at day 45, wow, patient A has the best response, right? But not only is patient A going to have the worst outcome, patient A, when you measure them, is already progressing the most as well, from nadir. So, this isn't really a static picture that we'd like to look at, but it's really, by having these 3 time points, you really can tell quite a bit about this data. And these 3 time points could all be acquired. Here I show it being acquired when they're starting to progress, as I showed previously, still even while early in their course of therapy. So G, the growth rate constant, is highly correlated with overall survival. Many advantages of it. We've now used these data sets and others to really see that, it works from a modeling perspective, but now we have to see how it works in actual clinical trials and with individual patients. So this is some of the data that we'll get. So these are 4 different patients, right? The tumors measured unidimensionally, bidimensionally, and volumetrically. So the red dots are the actual measurements that we have from the scans. The blue line is the curve, not that fits the data the best, but the curve that's derived from the formula of decay and growth. And look, I show these 4. I could take the next 10 hours and show the next 1,000, 10,000 of them. But for the most part, they look like this. You see that you get a different curve and you get a better fit volumetrically. And that's what we found, that this is a metric that, needs more of the data to really fit it better. And most importantly, you get a different G and a different D from this data, as you could see here as well. By the way, unidimensional, probably no, at least we've seen that it actually works better than simple PFS, but potentially we could do even better. So this is actually from multiple data sets from the FDA and others, just from tumor measurements, but from calculating the estimated median OS from an inverse of G, which is basically doubling time from the median OS from the literature, and the correlation was 0.99. This is Tito's work. Using QIN tools to do this, kind of finding a purpose for a tool. And this is Bin Zhang's work. And this is some of the segmentation and potentially the radiomics side of things. But most important, the FDA actually did their own analysis of retrospective data submitted to them. 24 trials, 2013, 2019, a whole mix of patients treated with different regimens. There was really a direct correlation between G and overall survival that they show here. And, suggesting that prospective studies are needed to evaluate whether G derived from early tumor measurements might serve as an earlier endpoint. We have to further fine tune G. We do want to share all of this data to socialize the use of G with other groups and statisticians, really to get people used to it. And it can actually be done simultaneously with prospective collections, which we'll start to do. I'll just go to this example. So this was a metastatic colorectal trial, Valor. So this is some Amgen data that they had given us, where the experimental regimen had a 6-week overall survival advantage. Now, somebody can question whether that should have been approved or not. It was, and we got the data, so we were happy. But basically, we did statistical simulations. That's a typo, sorry. Statistical simulations of phase 2 data from this phase 3 data. And we looked at where we would have a 0.8 power using G. And, the number volumetrically came out to 23 patients. Unidimensional did very well as well, but there were 1,200 patients that had been enrolled in the trial. Now, doing retrospective modeling and prospective evaluation is two completely different things. Getting our statistician colleagues all on board for this is not entirely, intuitive. I don't believe that the number's 23. I don't know if it's 50 or 100, but having seen a lot of this data, I'm also convinced that it's not 1,200 anymore, that we don't need 600 on each arm, and we could do with a lot fewer, to get this results. So, we're starting to think about a few different scenarios that we could use this in. Accelerated approval based on a difference in G or with a response rate, we call an enhanced response rate. By the way, we don't want to call anything, like new. We'll always call it modified. So a modified response rate, a modified measure of PFS, maybe that gets easier acceptance. Use of validated data as a virtual control arm. So, we have a lot of data in lung now, and we're hopefully going to work the CTIU with LungMap to get even more data. But, to really, let's get a library. The same way we know what PFS is in first line and second line, let's get a library of G, or if you want to invert that, it's tumor doubling time. Randomized control trials, discontinue the control arm if G or enhanced response rate of the active control arm is comparable to the virtual control arm. So these are some, hybrid techniques we could use to get people used to and accustomed to this. Rare cancers, we just can't get the number of patients. Let's definitely use this. So, that's really the two paradigms that we'd like to work on, with you, with AI, both for developing these, we have full AI pipeline together with Mike Knopp, who runs the core lab, who's processed a lot of this data for us to really develop this pipeline with existing trials, with new trials, and then, putting this through as well, the segmentation to get tumor burden and to see changes in G. Thank you.
Thanks so much. Yes, it's open for questions. Dr. O'Conniff, how about the microphone? Would you mind passing out the...
Can you hear me? Yeah, wonderful talk, and it'd be great to have an alternative to patients dying because the studies are just too long.
Yeah.
And if you could do the G and it would work. Now, all of your work, I think, is based just on CT scans, right? Now,
Yes.
no PETs, nothing else.
No.
And
Well, wait. So the G work previously that Tito has done has actually been based on PSA. It's been based on a lot of,
the G work, I'm
Yeah,
I'm
okay,
not
yeah.
questioning that. And
Okay.
it's for sure, we always knew that there was a subclone that was growing and you
Yeah.
just couldn't see it yet. And when you cut the specimens, you can see them. You can
Yeah.
see the little islands. So you know they're there. The question I was going to ask though is on a PET scan, you're kind of measuring the growing fraction, aren't you? Because tumors that are eating sugar are eating it to
Yes.
grow. It's not a perfect model, but it's related to that. So it would make sense, I would think, to include that. So for example, a lot of those pictures showed in the beginning where there wasn't any tumor shrinkage, there was just a texture change. The PET scan was different.
Yes.
So, and we as radiation oncologists have all gotten better at looking at those. For example, after you radiate somebody's liver mets, radiologists will sometimes, they used to say, they're smarter now, but they used to say, because they didn't have a PET scan, that the tumor got bigger, but no, that was our radiation effect,
Yeah.
right? And you can see the difference now because they look different,
Yeah.
and there's this center that's necrotic. How much do you want to just base this on CTs? Are you trying to put PETs out of business? I mean, it
No.
wouldn't be bad to do that, but
No, not at all. I think, for certain solid tumors that are more amenable to PET, this could definitely be done with that. We just couldn't get our hands on any of that data.
yeah,
do that.
yeah, that's what I imagined. right.
And if you, I mean, the obvious one is, PSMA, PET, and prostate.
And it would be hard to give up PET because after
Yes.
all, for lung cancer, you can really see small mets.
We don't
Right.
want to give up PET.
Right.
It's a good thing.
David?
Related question, how do you feel about possibilities for integrating our cone beam CTs? Because we have just troves of data and the image quality is getting better all the time for that.
Yeah, it would be fantastic to do that. And, boy, you could develop these curves. Now there, you would want to develop the curves with the features, right? Not just with the size. And
Right.
personally, I think that's where the holy grail is.
Right.
Right. So we have very solid evidence that at 3 weeks, we could see many, many reliable, reproducible feature changes. You could see it even earlier because you got the scans.
Right. And it gets to the question that every one of our patients asks is this working?
Yeah.
Right. They ask it every week during status checks. So.
Yeah,
Definitely.
and also it'll have like a daily data point.
Right.
Yeah, like I was looking at the curve and all this time point. Yeah, it'll be fantastic. Other questions? So I have a question. So the ultimate end game. Well, I know that this needs to be. This will continue to be refined. But if you have so you'll continue to working toward the perfect model to predict the outcome. And I don't know if the end game is the correct word, but what do you plan to do with the algorithm? Do you just have it available for everyone?
So yeah. So I mean, in all of our work, especially now, but it's always been, with these public-private partnerships. And quite frankly, even the companies want to be somewhat agnostic about this, right? And you see a lot of this radiomics work with these, 50 features or 40 features. I barely even believe that there isn't redundancy there and overfitting. But what I like to say is the degrees of freedom on a CT scan, and you guys know they're just not that great, right? You could just see so many things there. So I do think that we're going to be able to come up with a general signature, which is good for most therapies, or certainly within a therapy. And just like we have now modifications to our criteria for disease-specific things, for mesothelioma, for rectal cancer now, we may have some modifications to the signature. I think the modifications, if I have to guess, are going to be in the weighting of a few of these features, right? So well, one of our former colleagues at Columbia, when we showed him this baseline work on lung cancer, he said, "Well, yeah, great, you needed a computer to do that. I knew that patients with liver mets don't do well." That was, and of course he's right, but wasn't it good A, to prove that, B, to quantify it, and C, to potentially give a cut value over which we could run the next trial. So the weighting will be different, I think, but I think that we'll be able to come up with a few, kind of no-brainer tools, that you'll be able to understand and use.
Dr. Kachnik.
Larry, do you think at some point we will use this as a sort of go, no go,
Yes.
change therapy? Even,
Yeah.
I mean, for radiation too, in a way.
Yeah, and that's exactly what we want to do. In a data set that, a company data set that we can't show yet, but they took their stable disease patients, and we divided the 12-week stable disease patients into high risk and low risk, and there's a significant difference in overall survival. So the idea there is just to take the high risk, signature stable disease patients at 12 weeks and dose escalate or add another therapy for it.
It's almost like the interim path for lymphoma management.
That's exactly what it is.
A lot more sophisticated.
That's exactly what it is. Yes.
Yeah, so yeah, it's worth noticing, noting that if you have a 50 parameter model, you need 50 images to actually fit all the parameters,
Yeah.
and then it's a unique fit. So
Yeah.
it's so you have a situation where you only have 2 parameters,
Two
and
parameters. Yeah.
2 fit parameters, right?
Yeah,
So
two fit, yes.
so you need probably 3 dots, right? So how many do you need, and how often should we be getting them to have enough data to accurately measure G and
Well,
D?
okay, so so a minimum of 3, a maximum of a maximum reliably, 4 or 5.
But the timing of them matters too, right?
Yes, exactly. And then what you measure at the timing matters. Yeah, to me, the holy grail is going to be, baseline, 3 weeks, 6 weeks, 9 weeks, because I think that we can measure the changes there. It's more radiation, CT wise, but I think that we can almost get the full answer there and basically tease out those 2 components by then. We haven't gotten anybody to do that trial yet. Hopefully we will. I think we have to do some stuff with the regular data first and then back into it. But there's good evidence that, we see the features changes at 3 weeks. One data set that we've taken the 6 weeks and we've added a few features to it, and you see, better Ds and Gs as well.
Have you tried to apply similar techniques for, like, as a radiation oncologist after SRS, stereotactic radiosurgery? Very common question is this radiation necrosis or recurrent disease?
We haven't, but I know other groups have with radiomics, and they've done pretty well. Yeah, there's no reason to think. Well, you had mentioned that, you on PET you could start to see it. With immunotherapy, I mean, you could basically see it now, and that's all we're measuring here. Lymphocytes, whatever, they come into the tumors, they become more homogeneous, they become lower attenuation, they're a little bit bigger and fuzzier. Those are very unfancy words for what you're basically measuring.
Okay. Anyone from the virtual audience? Okay, well, thanks so much.
Thank you. Looking forward to working with all of you.
And yes, really,
Okay.
yeah, thank you. Okay,
Thinking outside of the box now. That's still on. Since we have all these cone beams, I was thinking, could we predict normal tissue toxicity? Could there be changes in the bowel For instance, on our pelvic patient, I mean, I have no idea. That's why I ask.
So I don't know either. But and you know some people that work lung toxicity. So high dose contrast against basically looking for weakness. It's really able to look at the immune related in the model. So there's certainly some information. I'm not quite sure of non-Hodgkin skin how much information is.
All right.
Thank you. Okay, let's move on. We have liaison report, starting with the breast. Now, Dr. Jaxie was here the other day, but she had to return.
Yep, but I'm on the phone.
But now she's here virtually.
Yep.
So, Reshma, the podium is yours.
Wonderful, thank you. You have my slides, correct?
I tried to load everything.
Would it be possible to show them? I'm not seeing them on Zoom, so I mean, I'm happy to. Perfect. Wonderful. I'll take the next slide. Thank you.
If you say next, I think they
Yep,
will move it for
next.
you here.
Next slide. I'll take the next slide. Thank you. Yep, next is great. Sorry, it's probably going slowly.
I can take care of it.
So it's really a pleasure to be reporting on the very active SWOG Breast Committee. We do have one of the open trials is a radiation-focused trial. Next slide, please. And that is SWOG 1706, which is a phase 2 randomized trial using olaparib as a radiation sensitizer during the radiation treatment for patients with inflammatory breast cancer. It is a randomized trial, so one arm gets standard treatment, neoadjuvant chemotherapy, modified radical mastectomy, and standard chest wall and nodal radiotherapy, and the other group gets the radiotherapy concurrently with 25 milligrams BID of olaparib. The trial is accruing quite slowly. We did only have a modest accrual goal of 5 patients per month, but even that accrual goal is proving challenging. So we have an amendment pending now to allow twice daily treatment in the control arm, which is the preferred approach at some of the largest centers, including MD Anderson, for treatment in this context, and hopefully will allow them to enroll patients. Next slide. We're also championing several trials in other groups, including the MA39 Taylor RT study, BR007 and BR008. I wasn't clear on who was presenting what, so I'm happy to present on all 3 of these, assuming that the champions are not presenting their own slides. Is that right?
Shane will be here. Eileen may make some comment. And
Great. What I'll do is
Corey will be also presenting virtually.
Yeah, Corey actually texted me and asked if I would present on his.
That's right. Yeah.
And so let me just, I did not include slides on these championed trials because I thought maybe Dean and Eileen would be presenting on those, but I can verbally update you on those. So MA39, next slide, I do have a slide for. That is the trial that is looking at essentially the node positive patients who have N1 disease and biomarker low risk, where we're not entirely sure they need regional nodal radiotherapy. So if they've had a lumpectomy, they get randomized to regional nodal radiotherapy plus post-lumpectomy radiation versus just post-lumpectomy breast radiation only. And if they've had a mastectomy, they get randomized to radiation or not. And there have been some amendments that have allowed inclusion of T3N0 disease, N1 Mike disease, that have changed to be a little more permissive in terms of the time to enrollment and the age that are included, just all in an attempt to get to this very ambitious accrual goal. And accrual is going well. We get relatively few credits for it, but I do believe that our SWOG medical oncologists who are helping make sure their patients hear about this trial when they're getting their their biomarker testing are contributing to the enrollment that we're seeing in the other groups as well. So that is all going well. BR007 is the trial in early stage, basically T1N0 women aged 50 to 69 who are postmenopausal and have biomarker low risk disease, and they are post lumpectomy, and they're being evaluated for omission of radiation therapy and only receiving endocrine therapy. That is actually accruing like gangbusters. The overall goal is something like 1,600 patients. Again, sorry that I wasn't sure if I was presenting on this one or not, but it is a very large trial, and it's already well underway. It's already meeting its monthly accrual targets, even relatively soon after having activated. And so all is going well on that front. And in fact, Dean may well be on that call because it's conflicting with this meeting is the BR007 update call. So I imagine he's not here. And then I don't know if Eileen is in the room and wants to speak to BR008, but that's the trial of omission of radiation treatment in patients with favorable HER2 positive cancer. It's just opened, and so I believe the first approval had just happened. Sorry, and
Oh.
Go ahead.
Reshma, sorry.
Yeah.
Sorry, I would have presented a slide. I'm doing it at the breast committee as well. The 500 sites have it open, and they've just had their first 3 recruitments. So it's actively started. That's basically what I've gotten at the last update. So.
Perfect. Wonderful. And I think this is it for my slides because I was told that everything else I usually present is going to be covered by other people. Is that right? Hopefully. Okay.
Did you want me to present the rest of the breast stuff? I can. That's not a problem.
Well, it's
I
I don't think there is any other breast stuff. I mean, there's the Shane is going to present the oligomets. One of you, I think, is going to present the rescue study, and then perfect. So you should present your own. Corey asked me to give an update on his.
Okay, perfect. You want to continue?
So, would you like to talk about it right now, Eileen, or?
DCIS is currently on hold pending the Astro APBI guideline update. That's going to sort of decide whether or not that's going to continue, but it's on a pause right now. And regarding the rescue, which is reirradiation for patients who had prior whole breast radiation or prior breast radiation who have a new primary and undergo lumpectomy and get reirradiation, is being revised. It was presented to the breast committee, and they made some comments, and it's going to be revised. So next time I'll have a slide based on that. So that's where those 2 are.
Perfect. And then Corey asked me to mention that the ribo with RT phase 1B trial.
I have a question. Could we?
Oh, sorry.
So in the DCIS IORT, is intrabeam allowed, or what are the? Yeah.
Yes, that was the concept. It was going to be any type of any type of low KV, but pending the update, because that's going to just kill it. I've heard nothing. I did submit comments because I do think more research is needed, but we'll see what happens.
So Corey's update on the ribociclib trial is that the 1B has now opened to provide safety data for the larger planned phase 2 within SWOG. And that is all he had to say. Oh, and I'll just throw in
Would you like to
lots of other
report before we move on to Corey?
Yeah, no, sorry. Corey's not here. So that was it for Corey. That was me presenting for Corey. This, I just was going to also emphasize that there's other secondary analysis work by radiation use and local regional outcomes that we published recently, that there's some really interesting translational medicine proposals, and Rachel Jimenez working together with Wendy Woodward, Corey Spears, and me will be looking at genomic signatures and local regional outcomes in SWOG 8814. And so lots more underway. Again, Corey was not able to make it, so he texted me and just asked me to present on his behalf. So I think the next thing we have is actually going to be Shane.
Hey everyone, sorry I couldn't be there in person this year. So this is a concept that is still in development. It's gone through a first phase, and I am presenting the original schema and then the revised schema, taking into account some feedback from the brainstorming session at the Breast Cancer Steering Committee. So this is hoping to build on what many of us saw as disappointing findings in BR002. Most of the people in this group are probably familiar with the fact that that study failed to show a PFS benefit in the phase 2 portion of the study, so the phase 3 didn't go on. The main criticism, I think, of BR002 is that that was a trial predominantly of metachronous recurrent oligometastatic patients. It was overwhelmingly hormone receptor positive. And those patients didn't necessarily get curative intent systemic treatment as part of that. So this is a concept that is aiming to address whether we can cure a minority of patients who present with de novo oligometastatic breast cancer. It's up to 5 lesions, excluding CNS disease, and patients in whom all of those metastatic lesions can be safely ablated with radiotherapy. Maria Rosenblit from Yale is the PI for the overall study, but this is going to be 3 trials that are running in parallel, 1 for each subtype. So Maria is overseeing the hormone receptor positive HER2 negative group. I'm overseeing the triple negative group, and then Nancy Lynn is overseeing the HER2 positive group. This is the original schema, and it was intended to take patients, again, with de novo oligometastatic breast cancer, give them subtype-specific neoadjuvant curative intent systemic therapy, and then for patients who had at least a partial response, randomize them to definitive local regional therapy plus ablative therapy to those metastatic lesions, versus just continuing with standard of care systemic therapy. The Breast Cancer Steering Committee felt that giving everyone intensive neoadjuvant systemic therapy was not justified, since that hasn't been shown to improve outcomes. And so this is the proposed revised schema, and they've recommended that we randomize patients at the beginning to either treatment per standard of care, which would be palliative systemic therapy, versus randomize them to intensive neoadjuvant curative intent like systemic therapy regimens appropriate for each subtype. And then for patients who have a response, randomize or go on to ablative therapy and definitive local regional therapy. For patients who don't have a response or progress, they'll continue with palliative systemic therapy and only receive radiotherapy for palliation. The last slide just has some of the statistical assumptions here. So again, these are 3 parallel studies that are all going to be conducted, sort of similar enrollment criteria. The assumptions are a hazard ratio of 0.6 for the hormone receptor positive and HER2 positive groups. It's a little bit less enthusiastic for the triple negative group, 0.67. And then we will build in some interim analyses. The Breast Cancer Steering Committee had suggested a phase 2/3 design, but that'll take a lot longer. And so the most recent iteration that we're going to propose will just do an interim analysis within kind of a large phase 3 design. I think that is all I have.
So this is Corey's slides he sent to me. So Reshma, you wanna just bypass this since you summarized them all?
Oh yeah, he said all he wanted me to say was what I said, which is the 1B is
okay.
underway. But why don't we show his slides just so people can see his schema really nicely? He did not give me any background beyond what you're seeing, so you can all interpret the slides as you wish. We
Also,
still see high rates of.
presentation-
I'm reading as you are. Yep. So we still see high rates of local regional recurrence in patients with substantial nodal disease. That's what those 2 slides showed. Next slide. This is showing that again. So yeah, it's probably not great for me to be going through these slides, but yes. So we want to improve treatment intensification by using a radiosensitizing strategy. And there's a good a set of evidence that Corey and his lab have developed suggesting that CDK4/6 inhibitors can radiosensitize ER-positive breast cancer cell lines. Next slide. While not radiosensitizing normal mammary epithelial cells. So very similar to the data that his lab collected for the olaparib PARP inhibitor radiosensitization. He's also collected now in this context. Next slide. So you can see here that this also occurs in vivo in mouse models. Next slide. And so they're developing a study of CDK4/6 inhibition that is concurrent with radiotherapy for patients with advanced non-metastatic breast cancer. And they've got it in a 1B trial. And I'm hoping to God the next slide is the schema, because that's really all I was ready to speak on with his 2-line text that I read you. Next slide. Oh, good. There is some existing clinical safety data suggesting that this is a tolerable combination, but there was a desire for additional safety data, so that's why there's work underway. Next slide. Oh, thank God. Okay, here is the phase 1B trial design that you can see here. And he just sent me a note saying it is now underway. And so we're just trying to keep interest up so that ultimately there hopefully will be, after reassuring data from the 1B, a progression to a phase 2 trial within SWOG that will look at this in combination with endocrine therapy and assess for changes in disease-free survival. And you can see the design of the SWOG phase 2 trial that ultimately one day will be proposed after the reassuring 1B data that is being developed undoubtedly emerges. I think that's probably it. Thanks.
Wow, Reshma, you are amazing. I knew you were amazing, but I think you can be a great stand-up comedian too.
I'm good at faking it.
A brilliant comedian too.
Thank you. Thanks.
Wow. Okay, great. Thank you so much. The next is report by CNS liaison. Tony?
Okay, all right. Thank you, Dr. Hahn. It's a pleasure to follow after Dr. Jaxie. So I'm going to do my best to continue on that momentum. So this is CNS updates. So as for those who aren't familiar, the CNS is within SWOG as a working group. It's not a committee. Although there's plans to change that. Next slide, please. So I picked out a couple select co-op group trials that it's not all of it, but those that I think are interesting and also would be helpful for those who are interested in accruing patients on these trials. So for example, this is NRG-BN009. This is led by Dr. Michael Chan at Wake Forest and Vinay Gandhi at Northwestern, looking at patients who have had salvage, who require salvage radiosurgery, brain metastases treatments to either get SRS alone or SRS with hippocampal avoidance whole brain radiotherapy, specifically in patients who have had a brain metastasis velocity of 4 or more METs per year at the first or second time. Next slide, please. I actually see Dr. Rustovan online, so I don't know if Chad, if you'd like to discuss the slide, or certainly I'm happy to. Okay, he may just be muted or in the middle of something. So this is the Maverick study. This is patients who have small cell lung cancer, either limited and extensive stage with no brain metastasis on MRI after first-line therapy. And the proposal is to give either PCI or just no PCI continued MRI surveillance, led by Dr. Chad Rustovan and Dr. Paul Brown, with MRI surveillance essentially every 3 months the first year, then 6 months at year 2. If Chad comes back on, I'll see if he wants to add anything else with respect to this trial.
Yeah, I think this is coming back later in the lung committee report too, in more detail.
That's one, yeah, that's great. So, okay, so next slide, please. So this is NRG-CC009. So again, just following the small cell trial from Maverick from Dr. Rustovan, the NRG-CC009 is a phase 3 trial of patients who have 10 or fewer brain metastases, randomized to radiosurgery alone or hippocampal avoidance whole brain radiotherapy using 30 gray and 10 fractions. And this is, of course, of big interest given the fact that at ASTRO, there was a presentation by Denise Bernhardt from Germany, randomizing patients to SRS versus whole brain. And so from that, I think this is the next study that we're looking at, specifically on hippocampal avoidance versus SRS. This is a concept from Rupesh from Miami Cancer Institute, randomized patients with limited brain metastasis, single versus fractionated radiosurgery for intact brain metastases. This is very similar to Paul Brown's Alliance A071801 trial that accrued very well, but that was primarily for patients who had postoperative brain metastases up to 4 brain mets, also randomized to single versus fractionated radiosurgery. And again, the primary endpoint similar to this was to look at local control rates at 1 year. Next slide, please. And this was the study schema. Note that the dosing for the SRS arms is slightly different than how the Astro has recommended in the past, but essentially it's all pretty conformal in terms of dosing for SRS or fractional SRS for these intact brain metastases. Again, primary endpoints 1 year local control rate. All right, next slide, please. So this is NRG-BN012. This is, I personally, we're currently trying to open that at our site. This is patients who have Stewart-Burry's trial, patients who have 1 to 4 brain metastases, of which one requires surgical resection. The patients are then randomized to either receiving pre-op SRS, the lesion that's planned for resection, or to receive post-op SRS to the resection cavity as per standard therapy. And it's up to 4 brain metastases. I want to make that of note. And so this is active as of earlier this year, and we're looking forward to more participation and enrollment in this study. Next slide, please. I want to point out this Alliance study from A071702. This is a phase 2 study of checkpoint blockade immunotherapy in patients who have somatically hypermutated recurrent glioblastoma. Next slide. This is from Gavin Dunn from WashU. And so these are in patients that have recurrent glioblastomas who are found Foundation 1 to have high tumor mutation burdens of 20 mutations or more, who then, who will then either receive Ipi-Nivo combination, and there's more response to move to stage 2. Next slide, please. And this is, there were 2 concepts presented at the CNS working group. So this is a phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed unmethylated MGMT glioblastomas. Next slide, please. So this was presented yesterday at the CNS working group along with Dr. Mayumi Ahluwalia's concept. I think I have the next slide of that. But so it's patients who have newly diagnosed GBM, unmethylated MGMT, who will get a single arm study of radiation atezotosi followed by atezotosi. This follows the similar dosing guidelines as used in BN011, which is for patients with recurrent glioblastomas who undergo surgical resection, re-irradiation followed by atezotosi. Next slide, please. And I believe this is the last concept I'm presenting here. This is TRC-102 and temozolomide in patients who have refractory or first-line newly diagnosed GBM, led by Dr. Ahluwalia, who is head of our CNS working group. Next slide, please. So this is a phase 1/2 study of TRC-102, which is a base excision repair inhibitor in patients with MGMT promoter methylation GBM. I'm just because of the time limit, I didn't have time to show some of the preliminary data, in particular for patients who had recurrent glioblastomas, that found that the TRC-102 drug was actually quite effective in patients who had methylated recurrent glioblastomas. But in patients who have newly diagnosed GBMs, we do not have that data. So this is a phase 1/2 study. And so thank you.
All right, thank you very much, Tony. Okay, the next is by Dr. David Horowitz. By the way, before I forget, all the presentation will be recorded and available from the website.
Wonderful. Thanks very much. It's a pleasure to be able to present to the committee. So there are several trials that we are championing here through SWOG. We don't have any open trials at this time that have a distinct radiation focus. So we'll talk a little bit about these championed trials and how they've been doing in terms of accrual. So the first one is NRG-GI006, which is a phase 3 trial of proton versus photon therapy for esophageal cancer. This has a primary endpoint of overall survival as well as grade 3+ cardiopulmonary toxicity. This is Dr. Lin's trial. This has been accruing decently. They're almost halfway done and have accrued 14 since our spring meeting in April. The next trial that we're championing is NRG GI003, which again is a proton versus photon study for hepatocellular carcinoma. This has been accruing less well, with only 4 since our previous meeting, and this has a primary endpoint of overall survival. The anal cancer study Decrease from ECOG Akron it's a phase 2 trial with looking at decreased radiation dose as well as decreased chemotherapy dosage for early stage anal cancer. This has a primary endpoint of disease-free survival as well as quality of life. This is accruing extremely well at 185 out of 252 total subjects, 26 since the last time we discussed this here. And then there are 2 metastatic trials similar to what was presented for the breast group that I think deserve a little extra attention. The first one is EA2183. This is a study that I'm championing. It's a phase 3 study looking at consolidative radiation in patients with oligometastatic HER2-negative esophageal or gastric cancer. This is an important study, but has been accruing very, very poorly, even after a revision, a modification of the study to allow for immunotherapy, given new data. This has only accrued 17 out of over 300 subjects that they're hoping to enroll, and only 1 in the past 5 months. And so I think that this study is definitely at risk to be closed if it doesn't accrue. The next one is colorectal cancer oligometastatic trial that's championed by Sep Golami, one of the surgical oncologists in the GI group. And this erasure study is a phase 3 study looking at a total ablative regimen for people with limited metastatic colorectal cancer. This recently opened, so they've just accrued their first patient. And again, this is looking at a primary endpoint of overall survival. And really importantly, you can have up to 4 metastatic sites on this study, and you can treat these with radiation, with surgery, or with IR ablation. But one of the sites has to receive SBRT. So radiation oncology is really central to this. And so if you're interested in treating these patients, I would definitely encourage opening this trial. As Dr. Kachnik pointed out, we are having retreats, and the GI committee is having a retreat tomorrow as part of the fall meeting. And they're specifically focusing on hepatobiliary and gastroesophageal cancers. And the goal is really to develop 1- and 5-year goals for their studies and try to think about across the spectrum of diseases, what kind of studies they want to develop and how they want to prioritize that. We don't have a lot of representation from radiation oncologists on that committee. I think there are only a couple of us who attend it regularly. And so I think that that really influences what kind of studies get promoted, right? The surgeons have a very good representation there, and you see that reflected in the studies that get advanced. And so I think that Dr. Fitzgerald is going to be, might be able to attend tomorrow, but I'd encourage other people who are able to come to participate in that. And again, they're trying to come out of that morning with at least 2 clinical trials to try to move forward. And then there's one study that we're continuing to work on for locally advanced anal cancer, really trying to build on the demonstrated efficacy of immunotherapy for metastatic anal cancer. And this is looking at a combination of PD-1 inhibition as well as LAG-3 inhibition. And in anal cancer, the local tumor microenvironment has a LAG-3 positive T-cell population. And importantly, while the LAG-3 positivity is associated with the response to Nivo, for patients who don't respond, the population of LAG-3 positive cells actually increases over time. And so this suggests that these patients might benefit from therapy that's targeted at that checkpoint. And so we have a schema, a phase 2 single-arm study that we're advancing through the the SWOG CTP mechanism with pharmaceutical company support for locally advanced or limited metastatic anal squamous cell carcinoma. And metastatic sites can be nodal sites up into and including the para-aortic chain, which can be treated definitively with radiation. These patients would receive neoadjuvant cemiplimab, which is a PD-1 inhibitor, and fianlimab, which is a LAG-3 inhibitor, for 2 cycles, followed by conventional chemoradiation and then additional adjuvant immunotherapy. The neoadjuvant setting allows for sort of a window of opportunity to look at tumor immune microenvironment changes, as well as HPV ctDNA kinetics. And the primary endpoint for this study is 6-month clinical complete response, which really correlates very strongly to disease-free survival. And the intent of this study is to try to generate a regimen that then can be moved forward for our next larger phase 2 or phase 3 randomized trial. So with that, skip these last couple. Move on to GU.
Great, thank you very much, David. Next is a report by the GU committee. James.
Thanks, Dr. Ha. Not a ton has changed since we last met. If you're going to pay attention to this GU portion, just pay attention to this one. This is Leslie Ballas's study, which came out of this committee, and it's finally moving. The concept was approved at CTEP and is now moving back to SWOG triage to move forward for full submission. This slide has actually changed, and if Leslie's on, can clarify, but we're simultaneously having the GU meeting right now, so I think she's on there. Where it says yellow IO, that's actually RT plus chemo now. Again, moving forward, very exciting study. It's for patients who've had a complete or near complete response to neoadjuvant chemo, or I guess perhaps chemo IO, who then subsequently decide they don't want a cystectomy. And this is a clinically relevant group of patients. This study is for them. They then would get registered for randomization to RT backbone, IO, or chemo with RT. So that's moving forward. Ongoing studies, SWOG 1802 is a multi-center trial of metastatic prostate cancer with standard systemic therapy plus or minus local therapy. And the radiation portion of the study is going very well. The surgical side is not accruing as well. And actually the radiation portion may cap soon. And so this is also an active area. If you have strong opinions on this, that they should continue the accruing to the radiation arm, I strongly encourage you to reach out to any GU committee members that you know, because I think it would be a shame to stop this study simply because there aren't any surgical accruals to this. SWOG 1806 is doing very well, almost done. This is chemoradiation plus or minus atezo. 434 patients out of 475 total. So this should complete soon. Your guess is as good as mine as to whether this will be positive or not, given recent outcomes with atezo from Empower. SWOG 1931 is a phase 3 study of immunotherapy-based combination therapy with or without cytoreductive nephrectomy for metastatic RCC. Does not involve radiotherapy, but accrual is going okay, 112 out of 332 patients. And then there's some ongoing studies as well that do not involve radiotherapy. So I'll just skip over that. There's a new study, SWOG 2210, which was just activated, which is a phase 2 study of neoadjuvant carbo for localized high-risk prostate cancer with germline BRCA1 and 2 mutations. Again, does not involve radiotherapy. So you can tell the theme, we pushed forward a study with radiotherapy, and hopefully we can integrate radiation more. We tend to champion studies more. This is GU 009 from NRG. The SWOG champion is Dr. Hong Zhang. This is accruing very, very well with 988 out of 2753 accrued. There's an escalation and de-escalation study for high-risk prostate cancer depending on Decipher risk. The intermediate risk kind of equivalent is GU10. I don't know if Dan Hamster's on, but this is also accruing very well. Again, escalation, de-escalation, randomizations, depending on Decipher score, less than 0.4 or higher than 0.4. And then GU11 is not accruing that great. This is Dr. Kuntz's study, Promethean, which is looking at oligometastatic prostate cancer with radiation with or without ADT, and that ADT is relugolix. It's accruing slowly. We have a new champion, Dr. Emily Wegg is going to be the SWOG champion pushing this at SWOG. Endpoints are conventional imaging, radiological progression-free survival, so perhaps relevant to the talk. There's some secondary objectives, and so a lot of radiographic detail will be collected and hopefully ripe for secondary analysis as well in the future. That's it. Thank you.
Thank you, James. The next is lung service. Henry.
All right, so we're fortunate today to be joined by several people who are going to talk about the ongoing studies as well. I'm going to first talk about the overall summary here is that we have something in basically every for almost every section of lung cancer. So early stage non-small cell lung cancer, we'll hear from Dr. Daly about SWOG 1914. Locally advanced setting, we hear from Dr. I'm not sure if Dr. Al-Jamali is made it quite yet from the disease working group meeting, but he'll be coming to talk about the borderline resectable, the borderline performance status, unresectable, locally advanced. We also have some other some champion studies as well in the metastatic setting, as well as small cell, and also I think we'll have Dr. Rustoven come for Maverick as well. So just to go quickly through the champion studies first before we hear from the active studies, LU002 is still on hold. It's been on hold for about 2 years now and still waiting the results of this for consolidated radiation in the oligometastatic setting. LU005 is complete in the US. We're just waiting for a few more patients from Japan to finally close the study, but it's accrued very well and hopefully we'll read out in the next year or so to find out about the value of actually adding immunotherapy concurrently and adjuvantly to chemoradiation for limited stage small cell. LU008 is accruing overall pretty slowly, but steadily up from 13 now to 15, but still out of 150. This is for using plural IMRT for meso. Raptor study is picking up a bit more. It was stuck at 40 for a little bit, but now it's actually almost up to 60. This is for extensive stage small cell lung cancer, looking at patients who are getting maintenance immunotherapy following chemoimmunotherapy, and then where they're adding consolidative thoracic radiation or not. It's actually not just thoracic radiation. It could also be to up to 5 sites of metastatic disease overall. This does allow for co-enrollment on so Raptor and Maverick, actually, which you'll hear about in a bit, which is a PCI study, do allow co-enrollment, which is really helpful. And actually, I had my first patient who were able to get credit for both for the same patient. The ECOG 5181 is almost done. It's accrued really well in unresectable stage 3 non-small cell lung cancer. It's basically probably going to finish in the next couple months. As you can see from the last meeting, it was 542 up to 626 now. And then this is for this study here, PD-L1 negative patients. It is now up to 31 patients out of 100. So PD-L1 negative, they're either getting IO or chemo IO if they're stage 4, and then the question is plus minus SPRT to a low dose, 24 Gray 3 fractions. So if we came from Dr. Daly now on S1914.
S1914 is a phase 3 randomized trial for early stage medically inoperable non-small cell lung cancer, comparing radiation alone to radiation with atezolizumab. Here's the schema for the trial. Our goal is to enroll 480 patients total who will be randomized. You can see the two arms here. The standard of care arm is, the control arm is simply standard of care SBRT alone for these patients. On the experimental arm, patients receive a total of 8 cycles over 6 months of atezolizumab. This is given as neoadjuvant, concurrent, and adjuvant Q3 week atezo. So patients initiate SBRT with cycle 3. You can see we allow anything from 3 to 8 fractions for the SBRT. So we were trying to be relatively pragmatic about the regimens that are used in clinics around the country. We do require that patients have at least one risk factor suggestive of a higher risk of recurrence based on either size, SUV, or tumor grade. The goal was to avoid enrolling the 1 centimeter low grade adenodes that were going to have almost 100% cure rate with SBRT alone. And then we have 3 stratification factors: location, size, and performance status. Primary objective is overall survival. Major secondary objective is progression-free survival, and then additional secondary objectives is shown here. And just a few key points. We started off quite slowly. We had the misfortune of opening this study about 2 weeks into the pandemic. So our first year was not good in terms of accrual, but we have really picked up now. Our target accrual was 8 patients per month, or starting off, we were at 3 or 4. Now we're at about 12 patients a month. So we're making up for lost time. That being said, we're just over the halfway point. So we would still love any additional sites, especially if you could have high volume accrual. We could still certainly use the help. We have tried to make this as pragmatic as possible in terms of flexibility with the radiation treatment schedules, anything from 3 to 8 fractions, and trying to limit the ineligibility, given this is typically a fairly frail patient population. There are 2 other open trials in this space, which has been one limitation to opening this at many centers. But I would point out a couple of points that I think are some benefits in favor of our study. First of all, we don't have a placebo, which many patients have expressed not wanting a placebo in this setting, especially in the medically inoperable frail patients. And we're only giving 6 months of systemic therapy. The other 2 trials are giving 12 months and 24 months respectively, which I would argue in this patient population may be excessive, particularly in light of the iSaber data that was published last month, where they received only 3 cycles of nivolumab and had a remarkable benefit in event-free survival with a hazard ratio of, I believe, 0.43. So I think that does really give some support to our study design. Accrual is actually now up to 263, so we're around 55% of target.
Thank you, Megan. And next, we have Dr. Algermiley.
Yes, thank you very much. I just want to make the quick point also that this has been a lot easier to sell from my practice as well, since the iSaber data came out from MD Anderson. Given that was phase 2 data, really does show some data now that suggests that adding immunotherapy to SPRT really has a good chance of being helpful. So now we need the phase 3 data. So I'm really happy to see this is really picking up their accrual.
Give the slides.
Oh, they're all here, so we can move it here.
No, it's yeah. Okay, thank you. So this is SWOG 1933, pilot study of hypofractionated radiotherapy followed by atezolizumab consolidation stage 2 or 3 patients with borderline performance status. In this patient population, so stage 3 with performance status 2 or stage 2 patients who are not surgical candidate, we don't have evidence, evidence-based data to guide treatment decisions. So stage 3 patients with performance status 2 are not enrolled on concurrent chemoradiotherapy studies, and stage 2 patients, really, we don't have data for concurrent chemoradiation. Standard of care has been surgical resection. And we know that the use of radiation with immune checkpoint inhibitors increases the efficacy of immune checkpoint inhibitors. So this is the basis of it. And there's, in terms of the use of hypofractionated radiation, 60 gray and 15 fractions, there was a study by Puneet Iyengar that showed the efficacy and no signal of increase adverse events or side effects compared to standard fractionation. So this was kind of like the basis for the study. We did it together. My co-PI is Tim Mitten. Inclusion criteria, as I mentioned, stage 3, performance status 2, stage 2 patients who are not surgical candidates. And then this is for step 1 enrollment. And then patients who get at least 45 gray of radiation, then go to step 2, which is atezolizumab, 1,200 milligram every 3 weeks for up to a year. Key exclusion criteria: autoimmune disease or history of grade 3 pneumonitis. So this is the study schema again. Stage 3, performance status 2, stage 2 patients who are not surgical candidates. This patient population is there. The key is to remember that study and screen the patients. My kind of I screened good number of patients. My main challenge has been this patient population who are borderline performance status or not surgical candidate. One of the requirements was or is a DLCO of 50% or higher. So this kind of like we had to screen few patients because of this. So that's kind of like the challenge, is to find patients who are, I think the patient population is there, but find patients who are reasonable lung function to be enrolled on the study. So it's a pilot study to kind of like make sure there's no safety signal and look for signal of efficacy. So we are at 30 out of 47 patients. So a small study, so kind of like 2/3 through the way. So our goal is to finish it and enroll the remaining 17 patients and finish the study. So kind of like I encourage everybody to remember the study. It's open 107 institutions around the country. So remember the study when you see this patient population. Yes.
Any comment? Okay, great. Thank you. I believe Chad is presenting remote.
Hey, Chad, are
Yeah,
you there?
thank you.
Oh, perfect.
Yeah, you able to hear me? This is the Maverick study, the SWOG S1827 trial, and this is a randomized trial for patients with small cell lung cancer, randomized to brain MRI surveillance plus or minus PCI. Next slide, please. So here's the schema, and this study enrolls both patients with limited and extensive stage small cell lung cancer, and it's a 1-to-1 randomization. All patients receive brain MRI surveillance, and it's are randomized to prophylactic cranial irradiation versus no PCI. The brain MRI surveillance schedule is every 3 months during year 1 and every 6 months during year 2, and hippocampal avoidance PCI is allowed. The primary endpoint of the study is overall survival with a non-inferiority design, and the key secondary endpoint is cognitive failure-free survival. Next slide. So some notes on the Maverick trial. So it's the first ever randomized trial of brain MRI surveillance plus or minus PCI for patients with limited stage small cell lung cancer. And in patients with extensive stage, there's been conflicting data on overall survival from randomized trials. And so Maverick is critical to resolving that conflicting data. In terms of status updates, so the trial was activated really coinciding with the pandemic in January of 2020. And as of October 6th, the study had accrued 181. It's 182 as of today. And our total accrual goal is 660 due to the non-inferiority design. So we're behind accrual in terms of our goals. I will say that the accrual has actually picked up quite a bit in the last 6 months. We've been averaging about 7 patients per month for the past 6 months. And for the previous 1 to 2 years before that, we were averaging about 4 to 5 patients. So things have been improving. We are in discussions with the NCI about taking steps to try to reduce our accrual goal to a more feasible accrual goal. And so our proposed change would be to make cognitive failure-free survival the primary endpoint, which would allow us to reduce the accrual goal to around 250. And that would be a superiority design with the hypothesis that MRI surveillance alone would have superior CFFS. And so if we do get approval for that, then and we're optimistic that they may be accepting of that, then that would put us at about 250. And we should be able to achieve that within the next year or so in terms of the accrual. And that would land us in the range of where the landmark randomized trials in the PCI space have been. The Japanese trial was 224 and the Slotman trial was 286, just to give you a sense. And so we do think that that still would be setting us up to provide practice-defining results. And we are still looking for more sites to open this trial. And for those of you who have it open, thank you for supporting it. And please continue to think about this for your patients. Next slide. And so then I'll move into a champion trial that's a related trial, also in small cell lung cancer patients, but in this case, in patients who've already developed brain metastases. And so this trial is NRG-CC009, and it's a phase 3 randomized trial of stereotactic radiosurgery versus hippocampal avoidant whole brain radiation for small cell lung cancer brain metastases. And this is led by Dr. Vinay Gandhi, and I'm the co-PI of this study. Next slide. And so for just briefly for background on radiosurgery and small cell, radiosurgery is now the standard of care for limited brain metastases for most tumor histologies. And this is due to multiple randomized trials that have shown similar overall survival to a strategy involving whole brain radiation, but better cognitive and quality of life outcomes with radiosurgery alone. However, small cell lung cancer patients were excluded from these trials. And for that reason and others, whole brain radiation has remained the standard of care for small cell brain metastases. But there are various lines of emerging data that suggest that radiosurgery may be a reasonable option for patients with small cell lung cancer. Next slide. One important piece of evidence comes from a large retrospective study that we participated in called the FIRE SCLC study that was published in 2020. And that was a large international retrospective that included 710 patients that were treated with first-line radiosurgery.
Any suggestion from the back?
He's not frozen. I see his eyes moving. Chad, can you hear us? Oh, he's reconnecting, it looks like. Yeah, because I see his. It looks like you're on mute again. Oh, and it looks like your audio is off, Chad. Now you're back on.
Sorry about that. Can you hear me?
Yes, we can.
Yeah, now, yeah.
Yeah, my apologies. The call just dropped right in the middle of the presentation. I'm sorry. This study was 710 patients that were treated with first-line radiosurgery with small cell. And the results were encouraging. As expected, we saw that whole brain radiation was associated with superior CNS control, but this did not translate into an overall survival advantage with whole brain radiation. And so that suggests that the trade-offs with first-line radiosurgery in small cell may be similar to other tumor histologies where radiosurgery is already well established. Next slide. And then hot off the press at ASTRO in 2023, there was some prospective data on this topic from the Encephalon trial presented by Denise Bernhard. This was a randomized phase 2 trial done at a single center in Heidelberg, Germany. And it was a randomization of radiosurgery versus whole brain radiation for patients with 1 to 10 small cell brain metastases. The whole brain radiation used in this trial was conventional whole brain radiation, that is without hippocampal avoidance. The primary endpoint was cognitive decline at 3 months using the Hopkins Verbal Learning Test, revised total recall. And so it was a fairly small study, 51 patients with 26 and 25 patients in each arm. For their primary endpoint, they found that radiosurgery was associated with less cognitive decline, 8% versus 24%. But you can see the event numbers there was 2 versus 6 events, so pretty small numbers. And my apologies, that p-value should say 0.07. So a strong trend and close to significance. And importantly, also, there was no significant differences in overall survival. So from that regard, radiosurgery looks safe. And so this is encouraging, and I would say hypothesis generating results from a small phase 2 trial. And certainly they appear to support a definitive assessment in a randomized phase 3 trial. Next slide. And so that brings us to the NRG CC009 trial. And again, this is the phase 3 trial of radiosurgery versus hippocampal avoidant whole brain radiation for 1 to 10 brain metastases from small cell lung cancer. And so the basic inclusion criteria: patients with brain metastases from small cell lung cancer, no prior brain radiation, including no PCI, less than or equal to 10 metastases, and a 1-to-1 randomization to radiosurgery versus hippocampal avoidant whole brain radiation. The primary endpoint is time to cognitive failure, and the accrual goal is 200 patients. Next slide. And so for a status update, so CC009 is the first phase 3 randomized trial comparing radiosurgery to hippocampal avoidant whole brain radiation. It's really, to my knowledge, the first phase 3 randomized trial looking at radiosurgery alone in any small cell population. The trial will, in our opinion, be essential to defining the role of upfront radiosurgery in small cell going forward. And it's been a collaborative effort in development with the SWOG Maverick trial. Patients on the Maverick trial who are randomized to MRI surveillance, who subsequently develop brain metastases, can dual enroll onto CC009 for the treatment of their brain metastases. The study was activated in February of 2021, and as of October, it's accrued 58 out of 200 patients. So that's a significant number of patients, and actually, you know, a little bit more than the randomized data that I just presented. But still, we have a fair ways to go here, and we're below our accrual goal, and we are looking for more sites that might consider opening the trial. And you know, for sites that do have it open, we appreciate you continuing to consider this trial. We really do think it has the potential to be practice changing and very important going forward.
Great.
Thank you.
Thank you, Chad. Okay, let's move on back to Henry.
All right, thanks very much. We spoke about this before, so I'll be quick. This is just the trial concept we have going on now for Pacific versus induction chemo and immunotherapy, followed by Pacific regimen for unresectable stage 3s. And we're talking within our group also about looking at borderline resectable and unresectable, and the kind of what we call aspirationally resectable patients as well, because I think there's some room here. There's actually in our radiation subcommittee meeting yesterday with the surgeons some talk also about potentially resurrecting the idea of doing a chemo RT versus surgery study in this space as well, actually led by the surgeons potentially. So we're hoping that we could do something in this space too. So just overall, we have a lot going on in the lung group, as you can see, and we're excited to hear more about to get any questions from you all afterwards. So, yes. Right now, we're working on getting into executive committee, so we're working on that. Thank you.
Right, thank you, Henry. Okay. The next is report from the lymphoma committee. Dr. Sandy Constein is the liaison, but he has conflict. So I'm presenting on his behalf. Click on the screen. Okay, so I have 3 studies to report on. S1826 is a randomized trial for advanced Hodgkin lymphoma. Randomization was between 2 arms. One arm was nivolumab and AVD. The other arm was brentuximab vedotin and AVD. And radiation therapy was risk-adapted depending on the PET finding at the end of chemotherapy. And as you know, this was a plenary session presentation at ASCO this year with 12.1 months follow-up, median follow-up. The nivolumab arm came on top in terms of progression-free survival. And longer follow-up is needed, of course. And the next study is a early stage Hodgkin lymphoma study led by SWOG. This is for patients with early Hodgkin lymphoma, and they are treated with 2 cycles of ABVD. And if the interim PET is negative, the patient get randomized between ABD times 2 to 4 cycles, depending on the prognostic factors. And the other randomization arm is brentuximab and nivolumab. And if the interim PET is positive, patient get randomized between dose escalated beer cup, followed by involved nodal radiation therapy. And the other arm is brentuximab and nivolumab, followed by involved nodal radiation therapy. And it just opened and the enrollment has been steady. And the last one is another study led by SWOG. This is for patients with primary mediastinal B-cell lymphoma. So basically, patients will get treated by a standard chemotherapy, either R-CHOP or dose-escalated EPOCH-R, but the randomization comes to nivolumab with or without. And radiation therapy is for the patients who are to be treated with R-CHOP, depending on the end of treatment PET scan. And of course, if the biopsy is positive, at the end of treatment, the patient will get radiation therapy consolidation. Now, before we move on to melanoma, I don't know if Dr. Jeff Wang is available online.
Yes, I'm here.
Would you be able to do screen sharing?
Yeah, I'll share screen. I'm gonna go quickly through what you asked me to present. Can you see that yet?
So basically, this is what he presented at the stem cell and bone marrow transplant committee this morning. It's concept as I sent you email about.
Okay, thanks, Jewel and committee members. I'll go quickly. This was presented this morning at the transplant committee meeting. They asked to present our experience and potential trials that could be done through SWOG. So let me just go through these slides. TMI at our institution was done to develop to address the challenges.
We don't see the slide. Somehow we don't see it in the main screen. I see it in my computer.
Okay.
Yeah, other people that are on Zoom can see them.
You can, but not in the room.
Okay, there you go. Yeah, go ahead. Yeah.
Okay, thanks. Again, we wanted to address the challenges of TBI. I think we all know side effects, acute and late. You can't give TBI to older patients, even though AML tends to be in older patients. Inability to add TBI to reduced intensity regimens and inability to dose escalate. This data was available at the time we developed the concept of TBI. This is a phase 2 randomized trial at Fred Hutch, AML in first remission, randomizing between 12 and 15.75 grade TBI with PSI, with long follow-up. And it showed that dose escalation could potentially reduce relapse rates and create some durable remissions. But early on, there was an increase in non-relapse mortality, which offset any survival gains. The toxicities tended to be hepatic or renal, but there was also acute GVHD and mucositis. And they saw these differences in relatively small numbers of patients in each arm, suggesting maybe it's on the steep part of the dose response curve. So we developed TMLI, as this is sort of a summary of the type of dose distributions we've created with various trials. I'm only going to focus on the trials that lead to the concept proposals. These are all the organs that we contour. We now have software to auto contour. These are the target regions initially, bone and bone marrow. We called that TMI. This was an initial tandem autologous transplant trial myeloma. We no longer do TMI in myeloma because of other options that they have, but we moved toward acute leukemia, and that's the majority of our patients. They are go through an allo transplant. We added lymph node and spleen to get the immunosuppression needed for allo transplant. We use the term TMLI. And in older patients, we've escalated towards not so much 18, 16 gray at this point in time. We see a color wash here. For the younger patients, we've been a bit more, been able to be a bit more aggressive. We've escalated successfully to 20 gray, to bone, lymph node, spleen, liver, and brain kept at 12 gray. And again, in younger patients, less than 60. You can look at this color wash, which this represents also as a form of multi-organ sparing TBI with boost. Our mandible and maxilla are not target regions to try to keep the oral cavity dose down and keep the mucositis down. We kept the fractionation scheme from the beginning similar to standard TBI because of all the other variables that were changing, including dose rate, which is at 70 to 160 centigrade per minute, average dose rate. And we kept the total dose to the target regions to 20 gray since planned comparison studies with standard TBI using lung blocks showed that the lung doses began to approach those of standard TBI once we got up to 20 gray. This one slide summarizes the workflow. I'm not going through all the details, but basically they're simmed in the supine position. Again, we have auto contouring tools, which we can share, which cuts the contouring time down to 2 hours. The basic point of this slide is that we can do these therapies on a variety of different platforms. At our site, it's either a TrueBeam VMAT approach or chemotherapy approach. And really the planning and treatment time is about the same. We have now a dose and DBH library of approximately 120 patients. So that really helps to speed up the planning process. And again, that's something that's shareable. Now TMI and TMLI was developed at City of Hope in the beginning to address an unmet need. This is to provide a radiation-containing regimen to patients who really didn't have any good standard transplant options. These were patients with active disease who usually don't have go into a transplant, or patients who were older, again, who could not tolerate TBI. As I mentioned, we wanted to reduce toxicities, dose escalate. We've treated over 500 patients to date on various trials. We're going to focus on the acute leukemia population. The first population were the older patients with relapsed refractory disease, as well as the younger patients with relapsed refractory disease. Historically, you can see on the graph on the right, the survival rate's about 20% at 3 years. So this is what we wanted to improve upon. With regards to the younger patient population, phase 1 trials showed that we could take the dose up to 20 gray. So we're now in a phase 2 study that's about to end with relapsed refractory patients, mostly AML, younger patient population, as I mentioned. I've mentioned the target regions in the previous slides. We reported at ASTRO the first 57 patients. These were patients, again, with a lot of tumor burden, normally would not go to transplant. These were patients in induction failure, mostly AML. Almost all the patients had detectable blasts in marrow and half had detectable blasts in circulation. The mean organ doses were 20 to 51% of the prescribed dose. Here's a breakdown of that. The oral cavity dose is low. Going forward, we're trying to reduce the GI dose, and we are now able to reduce the lung doses, usually to less than 8 gray. This is some data from this phase 2 trial, which is now up to about 70 patients with similar results. The 2-year estimated progression-free survival is 33%, overall survival 48%, which is encouraging. Low toxicity, the non-relapse mortality rate is 9%. No significant differences from what we could tell between AML and ALL. We then also applied the TMLI strategy to a post-transplant cyclophosphamide. PTCY is a way to reduce GVHD. We took the Hopkins regimen, and instead of 2-gray TBI, we replaced that with TMLI to 20-gray in a younger population. We're able to escalate to 20-gray, and those results have been published. Now we've kind of began to evolve away from just active disease. You can see there are high-risk CR1 and CR2 patients in this group. And in this report, we were able to get to 20-gray, as mentioned. Again, low NRM rate at 2 years, 13%, encouraging survival rates, relatively low GVHD rates. We felt we were able to dose escalate safely without increase in GVHD or NRM, and we have a phase 2 trial that's ongoing. This last trial is really the basis of one of the concepts that we proposed this morning. This is in now a patient population that would normally go to TBI or perhaps to BUSI. These are patients with AML in first remission. This combines basically TMLI alone. There's no chemotherapy before the stem cell infusion, plus post-transplant cyclophosphamide for the reasons mentioned earlier. You can see the schema here. The color wash is similar to the previous TMLI dose distributions in the younger patient population. This is in patients with a matched donor. And again, AML and CR1, CR2. We're following the standard endpoints, but also a composite endpoint called GRIFS, which is GVHD-free and relapse-free survival. We already published on the first 18 patients. We're up to 30 patients now with similar results. And all patients engrafted with good recovery kinetics. It's well tolerated up to age 60, and now we've extended the age limit to 65. No grade 3-4 toxicities and no deaths. With 2 years follow-up at the last publication, again, low GVHD rates, encouraging overall survival rates and leukemia-free survival rates, a NRM rate at 2 years of 0, and a GRIFS rate of 60%, which compares favorably to our historical control, which is the third bullet item, with TBI 13.2 gray and SIRE or etoposide 39% at 2 years. So phase 2 trials underway. And this trial is also one of the underpinnings of one of the concept trials we proposed. Again, the older patient population, they can't tolerate TBI. They undergo reduced intensity regimens such as fludarabine and melphalan, but there can be an increased relapse rate with that. So we wanted to look at the feasibility of adding TMLI onto Flu-Mel. The pilot trial was with 12 gray and Flu-Mel, as you can see here. 61 patients who were last reported on in 2018. You can see there's a mix of patients, all with high risk, some with prior transplants, so with comorbidities, mostly AML patients. This trial was very encouraging. We have long follow-up with a plateau of the event-free survival and overall survival of 42% and 41%. Very encouraging. Certainly looks better than the historical 20%. The NRM rate is a bit higher because of the older population, but similar to fludarabine and melphalan, we feel. So the proposed trials, the first one was in patients with MRD positive. They still have active disease going into transplant. It takes the Flu-Mel backbone, adds the TMLI, as I mentioned, and it's a randomized study or proposed randomized study to best non-TMLI options. And then the second concept was in the patient with AML in remission, in a way as an alternative and potential replacement for other standard myeloablative regimens. This time adding PTCY also to both arms. I'll just say that the committee, the transplant committee, lots of questions about the feasibility of doing this in SWOG and how many centers would be able to and would be interested in doing TMLI, given the time that it can take to deliver the dose. We feel that if you're already doing TBI, this shouldn't be too much more effort. From our perspective, it's about the same effort. And then I think the other primary question was perhaps a randomized trial of TMLI conditioning regimen versus a TBI conditioning regimen to kind of really compare TMLI dose escalated to standard TBI. So I'll stop there. Thank you for your time.
Thank you very much, Jeff. So for the sake of time, we will move on to the next presentation. Do we have Evan here?
Yeah, thanks very much. I'll go pretty quickly because there's not really a lot that's necessary to update folks on since the last call. So just to remind, so SWOG 1801 was a really important phase 2 randomized study that the conclusion drawn is that neoadjuvant pembrolizumab in stage 3 melanoma is better than adjuvant, but it was a phase 2 study. So the FDA has looked at that data and basically has said that in order for approval, we need to do a phase 3 study. So the melanoma group, one of their big things that they're working on during this meeting, and I've been back and forth between our meeting and the melanoma meeting because they're going on concurrently, is basically coming up with all of the details of that phase 3 trial. So that's really that's one of the main things that folks were going to do. We have 4 different trials that are going on in melanoma, but none of them really have to do with radiation therapy. There are a couple studies that look at the arrangement of the available therapies in BRAF mutant patients. So should they get MAP kinase pathway inhibitors first, or should they get immunotherapy, or should they get all of the available therapies at once? There's a study a surgical study looking at margins of excision, and a study adding another immunotherapy agent to the Nivo/Ipi backbone. And then just there's a non-SWOG cooperative group trial out of ECOG Akron that looked at Merkel cell carcinoma, and that trial has been fully accrued. That was a adjuvant immunotherapy trial looking at whether pembrolizumab could improve the survival of patients with stage 2 and 3 Merkel cell carcinoma. And so that trial nationally is and lastly, there'll be some trials that are percolating through looking at cutaneous squamous cell carcinoma. That's become an area of interest. It's been a very difficult area to study in the past because it's a really heterogeneous group, and a lot of the patients have something wrong with their immune system that usually makes them difficult to study on trial. But there was a clinical trials planning meeting that was run by the NCI earlier this year. And so there'll be some different trials that probably come out of that. So that's the short version of the update of what's going on in the skin cancer world for y'all. So thanks.
Great, Evan. Thank you. Let's move on to the next one. We have sarcoma. Jeremy? We have some faithful remaining.
What's that?
Faithful members.
Yeah, I'll keep it brief as well. Thanks so much. So this is a concept that has been in development, both from the Radiation Oncology Committee as well as the Sarcoma Working Group, which is under the Early Therapeutics Committee. So this is now a phase 2/3 randomized trial of radiation fractionation schedules for high-risk extremity sarcoma. So the standard of care for pre-op RT is 50 gray, 25 fractions defined by RTOG 0630. There's a lot of studies that have been conducted and completed now that have looked at various short fractionation schedules for this population. Whenever we hypofractionate, there's a concern about toxicity, in particular late toxicity, which in the sarcoma population comes to mean joint stiffness, edema, fibrosis, wound complications, bone fracture. There's not a lot of long-term data from these studies and no head-to-head comparison with conventional fractionation. Acute wound complications seem comparable. with one exception of perhaps delayed wound healing. And so we want to show non-inferiority with one of these hypofractionated schedules. This is the schema. It's a 3-arm study. The control arm is arm A, conventional fractionation, 50 gray. Arm B is ultra hypofractionated, 30 gray 5 fractions. Arm C is hypofractionated, 15 fractions, 4275. Stratification by tumor size and location. Surgery would be 4 to 8 weeks after radiation, and optional chemotherapy and radiation boost for positive margin growth disease. So the primary objective of the phase 2 portion is to select one of those 2 experimental arms to carry on to phase 3 on the basis of local failure, late toxicity, acute toxicity, delayed wound healing. And the change from the last presentation to this group to now is the splitting into a phase 2/3 design. And that was based on some early discussions with NCI. We're really happy that they were open to having toxicity as included as one of those primary endpoints for the phase 2 portion. And they'd like us to select a winner using hierarchical testing on the basis of local failure and then toxicity. And I've included, I'll skip over kind of like what defines those toxicity endpoints. This is kind of the hierarchical design. So local failure will be compared between control and experimental arms. And if inferiority were met, then that arm would be dropped. If not, then we'd go on to late toxicity comparisons between experimental arms, then acute toxicity, and then delayed wound healing. If none of those endpoints are met, then we would go on to evaluate for early signal on the basis of some boundaries for those endpoints that we've established. More straightforward is the endpoint for phase 3 test, which will be on the basis of local failure. Secondary objectives I've listed here. The design is a 3-arm. The phase 2 3-arm design has 75 patients per arm, and the phase 3 has 147 patients per arm. And that's a non-inferiority estimation at 2 years, benchmarked from RTOG 0630. There will be some safety analyses conducted after 30 and 60 patients. And then here's more detail about eligibility criteria. I've highlighted the most important ones being extremity sarcoma only, non-chemotherapy sensitive, not bone sarcoma, with a plan for limb sparing surgery. All right, thank you.
Thank you very much, Jeremy. Now, the last presenter, not the least, Eileen.
So just to keep this very brief. So from the prevention committee, okay, so here's my slides. So in the prevention committee, these are just some current active studies, none of which involve radiation. The trials in development, so I had a trial that was in development looking at intraoperative radiation versus no IRT for low risk DCIS. This has been put on hold. DCP wanted some pilot data, but then pending the ASTRO APBI guidelines, we decided to put it on hold temporarily to see what that comes out to say. There was another study also on DCIS looking at low dose exemestane or tamoxifen that was also disapproved by DCP. So they don't seem very enthusiastic about DCIS, at least coming from SWOG at the moment. So there's nothing else really in the prevention committee. Cancer care delivery has also a few trials that are currently open, mostly looking at financial toxicity and educational tools. And there's a few things in development, and I'm just going to focus briefly. Erin Gillespie, who is now at University of Washington, actually presented a concept at this meeting, which is in its early phase of development, looking at implementation science and digital health to promote evidence-based management of cancer-related fatigue. And so this is just a 1-slide representation of the preliminary design that she's proposing, which is to use Patients who have stage 1 to 3 breast cancer undergoing radiation and any reports of fatigue would be randomized in a 2-to-1 fashion. Arm 1 is those that would be given on their electronic portal patient prompts to enroll in an at-home exercise program, as well as to report their progress with physical activity. And they'd be looking at providing them these prompts either during radiation or at 60 days after radiation, versus a control arm, which is the usual standard of care, paper handouts linking to the at-home exercise. And her primary goal is to look at how the patient reported physical activity using the pros. I think the standard arm would ultimately be given the pros to look at their activity, and then secondarily looking at fatigue and depression and other patient outcomes. So this was received well, and she got a lot of feedback. So I think next time she was hoping to present it herself here, and it'll be probably updated more at that time. So that's it.
Thanks so much.
No problem.
Okay, we are almost done. So, as you know, we have been looking for the liaison for some committees, Cancer Survivorship Committee, Symptom Control and Quality of Life Committee, Immunotherapeutics Committee, and Early Therapeutics and Rare Cancer Committee. Now, Lymphoma Committee, Dr. Sandy Constein is going to step down. We have a term limit. So we are looking for applications, and once we get application for any of these liaison position, we'll review it with the executive officer of our committee and also the corresponding disease site committee leadership, and make the selection. Now, one quick question before we say goodbye is, so we are having monthly committee call on the 4th Thursday of each month. I know there's no perfect time that's going to fit everyone. How is it working out? Well, it looks like it's going to work out. Okay. Thanks very much. And thank you for staying late. I try to be in time. I'm on time next time around. Okay. Thank you. And